Hello, we want to welcome everyone to this presentation, this webinar, and I'm Art Wood, Senior Vice President of Marketing and Development at PSI. I want to introduce Karen McKinney, who is going to share a little bit about what PSI offers for the Fabry and Pompe communities, and then Jim Romano, who's our Director of Government Relations, who will be talking primarily about the subject matter on the Affordable Care Act, the exchanges, and how it impacts patients. So before we get into that, I wanted to quickly introduce PSI, and before I do that, I want to thank Amicus Therapeutics for their sponsorship of this webinar. PSI has been around for about 25 years. We started with an individual named Dana Kuhn, who himself has a chronic illness and lost his wife to a chronic illness, was left with 2 young children, moved to Richmond, Virginia, began working at the Medical College of Virginia here in Richmond, counseling families, primarily with children, dealing with terminal illnesses. And he was finding that they were spending down everything that they had, selling a house, moving into an apartment, selling a car, even getting to the point of having to involuntarily divorce so that one might be able to get public assistance for the child. Then the child would pass away and they would be dealing with financial devastation. Dana Kuhn is a problem solver. He wanted to try to find a way to address this. He realized that the 2 primary ingredients are making sure that patients have a reimbursement vehicle, and secondly, that they're able to pay for that and pay for the out-of-pocket costs. So he started a nonprofit, Patient Services Incorporated. We've been going for about 25 years. We were the first to offer premium assistance, and in the 90s began offering out-of-pocket or copay assistance with the expensive biotech drugs. People were going to the drugstore and finding that they had a $200 or $300 out-of-pocket cost and simply couldn't afford that. So we are a nonprofit that can provide assistance in a number of different areas. I'm going to ask to advance the slide. We certainly work in Fabry and Pompe, but we have expanded from biologics, hemophilia, IVIG, alpha-1, and similar diseases to enzyme deficiencies to oncology. The programs we offer in each of the disease areas will really vary depending on the patient population, but I'm going to let Karen McKinney explain a little bit about what we offer for the Fabry and Pompe communities and how they can receive assistance here at PSI before we turn it over to Jim Romano.
Good morning. PSI offers financial assistance through our Fabry and Pompe programs to include health insurance premium payments, out-of-pocket assistance, which includes co-payments and co-insurance payments for your drug, infusion, physician, and diagnostic testing. We also offer incidental expense program, which allows reimbursement for the mileage from your home address to your treating physician. This program also covers lodging reimbursement if an overnight stay is needed when you're having treatment. In order to be eligible for the program, PSI reviews certain criteria to determine eligibility, including diagnosis and treatment, financial review, and insurance. For diagnosis, a patient must be receiving an FDA-approved product for ongoing treatment. For household income, PSI will request your most recent income tax document to ensure your household income meets this criteria. An overview of our application process includes completing the online application from our web address located at the bottom left-hand corner. When completing the online application, there are 4 simple entries which include patient demographics, insurance information, physician information, and household income. The second step is to follow up with sending documentation to PSI. This would include your most recent tax form and insurance policy paperwork. We are looking for documentation that supports your insurance premium amounts and the payee information. This could be an insurance policy invoice, Social Security awards letter identifying the Medicare premium deduction, or even a pay stub if your family receives insurance through your employer. After receiving the completed application, our patient service representatives review the application and your eligibility status. When approved, we will mail you an approval letter which explains the program information on maintaining assistance throughout the year. Patients can receive reimbursement in a number of ways. For most insurance premiums, we will pay the insurance company directly. If you have insurance through your employer, or if your insurance premium payments are directly taken out of your checking account, we will process a reimbursement check directly to you. For copayment assistance, PSI uses a PSI copay card that provides direct payment to your provider. The PSI copay card works for both your doctor and your pharmacy. And for travel reimbursement, a reimbursement check will be processed and mailed directly to you. And now I'm going to turn it over to Jim Romano.
Thank you very much, Karen, and thank you out there for signing in and looking over our webinar. I'm going to be going over aspects of the Affordable Care Act, which was passed by Congress in March of 2010. I know nobody has heard about it. It's been very quiet, and there's been no controversy whatsoever on this particular piece of legislation. The original intent was to phase in some of the components of the bill over a number of years. A lot of the patient protections and reforms, which are very important and which a lot of patient groups had advocated for, were basically phased in at the beginning of the program. I know PSI and a number of other groups very active in reforming the pre-existing condition exclusion period, lifetime and annual caps, and other of the protections that are very popular with patients. In 2011, we saw major changes to the Medicare Part D benefit, 50% donut, the 50% discount in the coverage gap, as well as other changes over some years where the coverage gap will basically decrease to 25%. 2012 and 2013 saw the expansion of and the building of health insurance exchanges, plus the Medicaid expansion infrastructure. So states really had the choice of whether they were going to expand their Medicaid and whether they were going to build exchanges or use the federal marketplace. And then starting just past January 1st, the individual mandates went into effect, which basically says that most individuals in this country have some form of coverage, or they were going to be subject to a fine or a tax. The goals of the Affordable Care Act were, very important. One was to expand the availability of insurance coverage to all Americans, which the law does very much do, and the practice of the discrimination of those with pre-existing medical conditions and medical histories, the removal of lifetime caps. There's an increased focus on disease prevention in the bill, working on different programs to take away some of the financial costs so that patients can get some preventative maintenance. And then, of course, they really wanted to reduce the trajectory of the cost curve, reducing the cost of health care. The jury is really still out if that's it's going to be successful or not. This is a many-year it's going to be many years before we actually understand the answers of these questions. So I know a lot of us are scared or concerned when we have to maybe pay a tax because we don't have coverage. But let me just assure you there's many forms of credible coverage that will count towards your individual mandate. First, obviously, is commercial health insurance coverage. And that you can receive that in a number of places. You have employer-sponsored coverage, individual coverage and plans that are currently available to people. And then, of course, obviously, they're building the health insurance exchanges / marketplaces so that patients have a place to go to obtain to obtain a policy. Another form of credible coverage is Medicare Part A. So for all of our senior citizens who qualify for the program when they hit the age of 65, or you qualify because of being disabled, you're considered to have credible coverage with your Medicare Part A. Of course, then another form of coverage is Medicaid. And obviously, with the expansion, it allows people to get who are between 137 and up to 137% of the federal poverty level to obtain coverage through Medicaid, the Medicaid program. There's also the state children's health insurance plans, or SCHIPs. They're still out there for children to obtain some health coverage. For all of our military families and heroes serving overseas, there is TRICARE for Life, which is the military coverage, which counts, again, as credible coverage. For all of our heroes who have returned home, who received their health care benefits through the Veterans Administration, that counts as credible coverage. There's also plans through the Peace Corps program, government plans like the federal health benefits and state and local plans. COBRA is still in effect. State health high-risk insurance pools are still operating, although many of them will be closing. And obviously plans through certain Indian tribes and the Indian Health Service are all forms of credible coverage. So the odds are you're pretty much, if you have current coverage now, that'll count towards your individual mandate, and you have a form of credible coverage. So these new health insurance marketplaces, I think they sound very exotic in my mind. Every time I hear about them, I think we're in the movie Aladdin at the Aqaba marketplace, and you can buy magic lamps and flying carpets and spices. It's all very exotic. These are going to be new competitive marketplaces, mostly online, where individuals and families and small employers can actually purchase a plan with standardized benefits and some form of cost sharing. The whole goal is to spread the risk between healthy, young invincibles, such as myself. No, just kidding, I'm not that young anymore. But and people with very expensive chronic conditions. By spreading that risk, it was hoped to keep costs down in the pool. Obviously, there's the structure and of benefits and provider networks will vary by plan. So if you do go to one of these new marketplaces, you're going to have to verify whether your provider is currently in network. Obviously, there's premium and cost-sharing subsidies available for those who do qualify for coverage, which we'll talk about a little later. So you can get help through tax credits and subsidies to pay for your premium and cost sharing. And for some populations, you can come to PSI for assistance. Each plan has to cover 10 essential health benefits. I highlighted prescription drugs. That's always the most important for a lot of our patients, is accessing the treatments and therapies necessary. It's not just your main treatment, but also any complementary treatments that you're receiving should be covered by the prescription drugs of your health benefit. Everything I tell you is subject to change, and you really do need to read the paperwork associated with the plan. That's the only way you'll have 100% knowledge of what's actually covered. However, as you can see, there's 10 essential benefits that need to be covered. These 10 essential health benefits have no lifetime cap and have no annual caps. However, possibly, if a treatment or a benefit is not considered essential and an essential health benefit, they could be subject to some kind of cap or higher out of pocket or not be covered at all. So it's very important that when you're researching your plans, you look to make sure that all your treatments are covered, even if there's some ancillary treatments that go along with your disorder. So there's types of marketplace plans. We like to say that they are standardized so that you can actually see which plan covers your treatment, what plan might not cover your treatment, or what basically their co-insurance is from plan to plan. You're allowed to basically, from an actuarial standpoint, I never knew what actuarial was until I got into this process, but basically what you pay versus what your plan pays, the actuarial value of your plan. There are 4 types of plans going to be offered actuarially through the marketplace. And they range. I feel like we're at this is Olympic season, and we could be at Sochi because they have bronze through gold, and they have a platinum, which they don't really have in the Olympics. But obviously, your bronze plans have are your, I would say, lowest. They have an actuarial value of 60%, which means the plan pays 60%, and you are responsible for 40% of your costs. Obviously, with a plan like that, your premium will be the lowest. A platinum plan, on the other end of the spectrum, your plan pays 90% of your average costs, and the patient is responsible for 10%. Obviously, your cost sharing will be greatly reduced, but your premium will be higher. There's also a catastrophic, or what they call limited benefit plan, in exchanges for those young invincibles under 30. It has been some time since I qualified for that plan. However, for younger people right out of college, or they'll have lower premiums, so these might be plans that will fit for the young invincible population. However, any of our children who have a serious chronic or genetic condition, these plans would not be suitable for them. So, what kind of ACA marketplace models are there? Well, states have the opportunity to choose. The state could create their own, or they could let the federal government do it. In the process, then, they came up with a partnership model. So let's go through them. 15 states, including the District of Columbia, opted to create their own marketplace. So they're responsible for all the functions: creating the website, plan certification, premium review, eligibility and enrollment, outreach, call center. The state does all the work. The federal government doesn't have anything to do except monitoring that it's following the federal guidelines. The federally facilitated marketplace is in 36 states, and the federal government does all the work. So the state doesn't even pick the plans. In some states they may. However, the federal government does everything from designing the web portal through basically helping them and patients enroll. State partnerships kind of sprung up in the process where the state wanted to pick the plans, do some premium review, but they wanted actually the federal government to build the website and do most of the technical work. So 7 states have opted to do this. Some of them include Arkansas, Illinois. So as you can see, there's the federal government is really running a vast majority of this federally funded, vast majority of the state marketplace models. Although this might change to various degrees as the years go on, as political situations change in certain states. This is very important for patients. Cost-sharing charges. So for every plan you have, you're going to have several of these different cost sharings. This does not include your premium of which you already are paying. These are the cost sharing that you'll have to pay for. Most plans will have some form of a deductible, which the enrollee must pay before the plan begins when you start receiving your benefits. So you have to satisfy a deductible before sometimes the plan starts paying for anything, whether it's $100, $500, $1,000, $5,000. You have to look about how much of a deductible you have to satisfy before the plan starts paying. You have something called co-payments. Co-payments are usually a fixed dollar amount on an item or service. Many people think of co-pays that you pay for your doctor's visit. When I take my daughters to the pediatrician, they have a $25 co-pay for the visit. So those are basically fixed dollar amounts on certain items and services. Then we have a term called co-insurance, and that is a percentage of the charge or cost of service or treatment, but you pay it in a percentage. You don't pay a fixed dollar amount. You pay 30%, 20%, 40% of your treatment costs. If your costs are if they're a very expensive treatment, you're going to have a pretty large cost. And that's where groups like PSI come in to help satisfy that for the patient so they can get access to that treatment that they desperately need. sometimes copays and coinsurance are juggled around. I just want everybody to realize they're not synonymous, obviously. Copayments are a fixed amount, whereas coinsurance is an open-ended percentage. Okay, so you really need to become an educated consumer. Like everything else we have in our lives, there's certain questions you're probably going to have to satisfy for yourself to see what plan you really want to obtain. The first question that comes to my mind is, what percentage of the cost do you want to pay for your plan? You could pick a plan with a lower copay costs, but you're probably going to have to pay a higher premium. If you want lower premium costs, then you probably will pick a plan that has a higher copayment. But it's kind of like a common sense. Plans with higher premiums will have lower out-of-pocket costs and vice versa. Another consideration for out-of-pocket costs are, what are the deductibles and out-of-pocket maximum costs for a plan? For silver plans, the out-of-pocket deductible and out-of-pocket maximums are $6,500 for individuals and $12,000 for families. Another question you need to really ask is your physician in network? It's a consideration. Does the plan cover your preferred hospital or site of care? It's very important that you know that where you've been getting your treatment, you can still, it's in network and you still can go to that place. Does your plan cover other patients' treatments? What if the copayment or coinsurance, what if any copayment or coinsurance for your treatments do you have? Is the treatment in a specialty tier, which you'll have a higher outpatient, higher coinsurance cost? These are the factors that you really do need to take into consideration when picking a plan. Affordability concerns. This is a great issue that we need to discuss, because you do have access as a patient in the marketplace to health insurance premium tax credits. And these can be advanceable or taken at the end of your tax year, but you can get help through the federal government to obtain premium assistance. A patient may qualify for a premium tax credit if you have an income between 100% of the federal poverty level and 400% of the federal poverty level. For an individual, that's between $11,500 and $45,000, $46,000. For a family of four, that's incomes between $23,500 and $94,000. So there is quite a bit of leeway to get your advanceable premium tax credit. You can also, patients also may qualify for a reduced cost sharing. For incomes up to 250% of the federal poverty level, you can get help reducing, but you have to choose the silver plan. That is very important to receive both a premium or a cost-sharing tax credit. So for individuals to get a reduced cost sharing, it's up to about $28,000, $29,000 for an individual, and about $59,000 for a family of four. So it is a varying degree between individuals and family plans. Again, let me emphasize, you have to choose a silver plan to get both tax credits for the premium and the reduced cost sharing. So how are these tax credits provided? Well, they're advanceable. So you can, when you go onto the website to choose your plan, you can put your information, and the credit is sent directly to the insurer each month by the Internal Revenue Service, the IRS. If advanceable, consumers, though, may have to repay excess credits at tax time. So when you get into with your accountant to do your taxes, if you have received a larger than tax credit than you were originally supposed to have, they will be making you repay that process. For those earning less than 200% of the poverty, repayment is capped at $300 for individual and $600 for families. There is no overpayment cap there for higher incomes. If you choose to do it refundable at the end of your tax liability period, you'll get it refunded with your when you file your income taxes. So for 2014, you can actually get it refunded to you in 2015. So that's something to look out for moving forward. Cost-sharing subsidies. So we talked about that. You must purchase the silver level plan. This will reduce your deductibles, your co-insurance, and your co-payments for covered services. Those with the lowest incomes pay only 6% of covered health care costs. That scales up to about 27% for those at 250% of poverty. So you see there is a difference. Okay, so we're talking about enrollment. Most, all exchanges were open for enrollment on October 1st, 2013, and that will go through March 31st of 2014. If you're not enrolled in credible coverage by March 31st, you may be assessed their tax penalty on your 2014 federal income tax return. Just a note of caution, to be covered for April 1st, you must be signed up by March 14th. If you sign up on March 15th, you'll be enrolled on May 1st. To enroll in a plan, go to www.healthcare.gov and pick on the state, and you should be able to start filling out the paperwork. If you don't have access to a computer, we have listed the 1-800 number, which you can call for a paper application. So we want to thank the different groups who participated, the United Pompe Foundation, the National Fabry Disease Foundation, the Fabry Support and Information Group, and AMDA, which actually worked with us to put this together. And I think that's a good place to go if you have additional questions, along with coming to PSI. Just one quick note, PSI works with many patient groups. We help organize state and federal advocacy days. We partner on state and federal advocacy issues, and we provide some technical assistance with letter writing campaigns through our CQ technology. So if you have any further questions, comments, or concerns, here's our contact number. If you have questions about the Affordable Care Act, please go ahead and give me a call or send me an email. If you have questions about our programs, please contact Art and Karen. I want to thank you once again for participating, and if you have any questions, we'd love to hear from you. Thank you very much.